So thanks everybody for coming. We have a speaker from Women's College Hospital today, who usually is one of a person that Eugene Christo works with, and the name is Tosin Osuntokun. She's originally from Nigeria, did her studies in Ireland, did a medical school, medicine as well as cardiology. I think you went to London for a bit, and now you're doing a fellowship in Women's College Hospitals. And I think Tosin is going to talk to us about POTS today, which is a syncope syndrome, which is something that we see a lot but don't really know too much about. So thanks a lot for coming. I think that there are a few EP folks online, and I think that we're going to have a great discussion. So thanks for doing this today, Tosin.
Okay, thank you. I'm going to share my screen. So you can all see this?
Yeah, that's good.
Okay, great. Thank you. So thank you so much for the invitation to speak today, and thanks for the kind introduction and the warm welcome. My goals for this talk are to go over the clinical presentation and associated features of POTS, understand the components that make up the diagnostic criteria, discuss some of the proposed underlying pathophysiology, and some current management options for POTS. This is the outline for our discussion today, and I'm going to start with a case. So this is a case from before the pandemic. It's a case that is probably pretty common to all of you in the audience. A 30-year-old woman who works as an intensive care unit nurse, very physically active, runs marathons, goes to the gym regularly, and prior to presenting to our clinic, noticed an onset of symptoms after a viral GI infection. This infection lasted for 3 days, nausea, vomiting, diarrhea, and she was bedbound for 3 days. Since then, she has daily lightheadedness, frequent palpitations, which is described as a very fast and strong heartbeat, and is totally exhausted after work and has to go straight to bed. She's had to significantly modify her life because of these symptoms. So just getting to POTS now. POTS is postural orthostatic tachycardia syndrome. And, sometimes I wonder, why is there postural and orthostatic both in the description of the syndrome? It's a reminder that, yes, there's tachycardia, but this tachycardia is also orthostatic, or in the upright posture. It was first described in case reports in 1993 by Dr. Ron Schondorf, who's an autonomic specialist in Montreal, and Philip Lowe. But it was really, described many years ago under different names: Da Costa syndrome, soldier's heart, irritable heart syndrome. So this is something that has been around for a very long time. The prevalence in Canada is unknown. The prevalence in the US is 0.1 to 1%, and maybe up to 3 million people in the US have POTS. It's common in young women, premenopausal women with a female preponderance. We know that there are delays in diagnosis associated with this condition, with delays of up to 6 years before people are diagnosed. And people have seen an average of 7 physicians prior to diagnosis. It is a chronic condition, a chronic disorder with impaired quality of life, functional disability, which impacts not just activities of daily living, but education and employment. There is increasing clinical awareness of this condition over the last number of years. And, you know, I will touch on the end in the recent 2 years, there has been a lot of talk about this condition. So, you know, what happens when we stand up? So really, we have progressed to the upright posture. You know, there are benefits, physiological benefits of being on 4 legs, because, you know, the head and the heart were on the same level, and that presumably mitigates the gravitational effect on cerebral blood flow. So when we're supine, you know, 1/4 of our blood volume lies in our chest. And when we stand up, immediately 500 to 1,000 mils of blood shifts to our pelvis and our lower limbs. This reduces venous return, reduces cardiac filling, reduces stroke volume, and all of this acts to activate the autonomic nervous system. And the corrective mechanism is to increase sympathetic outflow, increase heart rate and vasoconstriction to try and ameliorate these changes. A more longer term effect with prolonged standing acts through the renin-angiotensin system and the skeletal muscle pump. So POTS is a syndrome, and often with syndromes, that means that there are multiple ways or diagnostic criteria that is needed to identify these. So these criteria must all be met for a diagnosis of POTS to be made.
Tosin, can I just maybe just take, if you can just pause, I just want to take a look again. So heart rate 30 beats, no orthostatic hypotension, but symptoms. So really just increase in heart rate. Okay. And no other obvious cause. Okay, great, thanks.
Yeah. So this is from the Canadian Cardiovascular Society 2020 position statement, but it aligns with the American Autonomic Society criteria from 2011, also the Heart Rhythm Society criteria from 2015, and a more recent POTS working group from the NIH. So thanks, Dennis. You know, it looks pretty simple, and obviously, you know, if all of these features fit, then it's an easy thing to diagnose. So, you know, the 30 beats per minute increase is sustained, right, within 10 minutes of standing. I have here 40 beats per minute for people under the age of 19. We don't actually see pediatric patients, but some people may, so that heart rate cutoff is 40. There is no significant orthostatic hypotension. So that cutoff is 20 for systolic blood pressure and 10 for diastolic blood pressure. They have to have symptoms, and these symptoms have to be withstanding. And really, the symptoms should resolve when they go back to the supine position, and should resolve pretty quickly. The picture, both the hemodynamics and the symptoms, should be present for at least 3 to 6 months. And again, you know, it goes without saying, other causes should be excluded. Some of the tricky things that we have found that need to be taken into consideration are medication, anemia, endocrine causes. So these things really need to be assessed to make a diagnosis of POTS. What is a pathophysiology? There are multiple areas of investigation into the actual underlying pathophysiology of POTS. And at this point, it's not just one thing. Here we have hypovolemia, and a significant number of these patients have low stroke volume, which then when they're upright and they have venous pooling, they're going to have significant symptoms. They're going to have tachycardia, brain fog, palpitations. We have here people who have a partial peripheral neuropathy, so a small fiber neuropathy, where there's inadequate vasoconstriction, and that again aggravates the blood pooling. There are some cases where it's thought to be a primary issue with increased sympathetic activity. Here there's decreased norepi clearance with a family with a genetic mutation in the norepi transporter described. And this is where some of our medications can act to mimic POTS. And then we have here a lot of autoantibodies, some of which, the actual mechanism has not been described, but there is research, particularly Dr. Fedorovsky is doing a lot of research on autoantibodies. Some of them stimulate the beta receptors directly to cause tachycardia. Some of them might work through modulation of the muscarinic receptors. Some autoantibodies are involved in the peripheral neuropathy. The pathophysiology then leads to some of the symptoms that we talked about, and 90% of patients with POTS have lightheadedness, palpitations, and pre-syncope. Shortness of breath, tremulousness, chest discomfort often is described with prolonged standing, not so much the initial change in posture. There are other, problematic symptoms that are not orthostatic, and these really are the more challenging symptoms to address, particularly headaches and brain fog. People have chronic fatigue, they have exercise intolerance, they can have a lot of nausea, which again can limit some of the management approaches. And this nausea can be present all the time, whether they are upright or not. And then, a lot of GI issues as well, which can be challenging to treat. This leads us to the comorbid conditions that are associated with POTS. And, there's a lot more recognition of some of these conditions. Some of them, it's unclear what whether there's a mechanistic link, or whether it's an association because those conditions are common in this group of patients as well. So migraine is one of the most common. It's in about 40% of patients with POTS. And it can be a bidirectional issue where if their migraines are not well managed, then the POTS symptoms are problematic. And the question with migraine as well is there are some autonomic features associated with the onset of migraine. And is that, does that come into the association with POTS? We have here joint hypermobility and EDS. So hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder is pretty common in, or found commonly in people with POTS in about 20%. And again, it's thought that this might be contributing to blood pooling. because of blood vessel and collagen laxity. We work very closely with the EDS clinic in Toronto General Hospital. We refer patients to them and they refer patients to us. The issue with patients that have EDS is that they are not generally the people who are going to go into remission from POTS. They're really going to have long-term issues and a lot of flares depending on other conditions. Another significant coexisting issue is autoimmunity, with again close to 20% of patients with POTS having an autoimmune disorder. The most common disorders are Hashimoto's thyroiditis. A lot of them have rheumatoid arthritis or positive ANA and lupus. And there's a small number that have Sjogren's syndrome. Leading on from, the symptoms, the diagnostic criteria, and the comorbid conditions is this schema that was proposed by the CCS position statement in 2020. And here it's, based on the orthostatic tachycardia and the symptoms. So here you have somebody who has POTS, who meets the diagnostic criteria based on tachycardia, and they also have orthostatic intolerance symptoms. The plus denotes those associated conditions. So the EDS, the migraine, mast cell disorders, which mast cell disorders, again, for us, we have come to learn more about this. We see it in a significant number of our patients where they present with flushing, palpitations, particularly increased heart rate. They have multiple allergies. They have dermatographism on examination. And we have found that treating the underlying mast cell actually can help with the POTS symptoms and makes treating the POTS somewhat easier. When we suspect mast cell disorders, we refer. We're not allergy specialists or immunologists, so we refer to our colleagues at St. Mike's for help with the diagnosis.
So can you maybe Tosin, if you can just, so these patients would be, they have a lot of postural symptoms, but they might not be, some may not be tachycardic. So it's just a sensation that they have and they come and see you, which is interesting. Okay.
Yeah, I mean, so these ones here, where they have a lot of symptoms and they don't meet the criteria for POTS, we actually reassess. So we will repeat the standing test and we'll do it in the morning if we can at all, because the heart rate increases higher in the morning, just to make sure that we're not missing, POTS because they've had a test on a day when they're feeling good or, that they didn't quite meet the criteria.
Got it.
Yeah. This is again from the CCS position statement, but just to say that on the initial evaluation, you want to do a full history, but you want to do an autonomic, pay attention to some of the autonomic features. So bladder issues, GI issues, heat and cold sensitivity and intolerance, and any other historical features that might pinpoint you to some of the other underlying causes. Like often people will say, I was always very good at gymnastics. And when you ask them further, then they give a history of frequent joint dislocations, hypermobility, and then you discover that they actually have hypermobile EDS, and nobody had or they hadn't even thought of that from the history. Everybody should have orthostatic vitals. We, are lucky, pandemic aside, that we have the physical space and we have the staff to do orthostatic vitals on every patient at their initial visit, and in follow-up, depending on whether we're changing treatment or want to reassess. I must put in a caveat that, like all of us with the pandemic, we were not seeing, at a certain point, we were not seeing people in person. So that was a bit challenging to get the orthostatic vitals. We did take blood pressure and heart rates that were done at home from the patients. But really, for a diagnosis, those vitals should be done in a clinical setting.
There's a question from Suzette about what happens to the bladder, which I don't know if you have comments on that.
Yeah, so there are patients who have bladder dysfunction, so they have increased frequency and urgency that is outside of, say, a history of childbirth. They can have alternating constipation and diarrhea. They can actually have incontinence of urine. They can have retention of urine, and those kind of symptoms would make you think that, is there a wider autonomic issue going on? And that's where, you come here to consider referring to an autonomic center. We would refer to our neuromuscular colleagues at Toronto General if people had those kind of symptoms. Another autonomic kind of marker or issue is if people are very intolerant to change in temperature. If they describe an issue with sweating, either loss, complete absence of sweating, or excessive sweating, then we would refer them to the Autonomic Center and our neuromuscular colleagues at Toronto General.
Sounds good.
Okay, I don't have to belabor this routine lab work. We try and do a morning cortisol on everybody because we have come across 2 patients that I can recall with adrenal insufficiency, even though that's rare, but we have come across it. The decision to do further extensive investigation is obviously going to be individualized. If we want detailed autonomic and tilt testing, then we actually refer to Dr. Juan Guzman in Hamilton, who does these tests. Like everything, his wait list has been impacted by the pandemic, and there was a period where he had to close his lab. We have referred patients to Dr. Crystal at Sunnybrook and his colleagues to do tilt testing as well. I must say that the patients who have had tilt testing don't rate it highly. It can be a challenging test for the patients. I know we get the information that we need, but they're not usually volunteering to have another test. If we look here at the bottom, this is our group of POTS patients who, this is a heart rate in green, this is a systolic and diastolic blood pressure. So this is when they're supine, this is the head-up tilt, and the heart rate increases here. And the increase in heart rate is sustained while they're upright. There is no drop in blood pressure. And when they return to the supine position, the heart rate comes down again. doing a tilt can be helpful if, we really can't get to a diagnosis after the 10-minute stand. For example, the blood pressure and the heart rate fluctuates, or we have this feeling that the blood pressure is going to drop after the 10 minutes. We see that trend. Or if we're concerned that there's a broader autonomic issue going on. These are examples of other orthostatic conditions that can be elucidated from a tilt. So here is initial orthostatic hypotension, which you could pick up from a 10-minute stand. In fact, you pick up from a 3-minute stand. This is non-neurogenic orthostatic hypotension because both the systolic and the diastolic, or the systolic blood pressure drops, but here there's an increase in the heart rate to compensate for the blood pressure drop. This is someone with neurogenic orthostatic hypotension. Here you have a significant drop in the blood pressure, but you see here the heart rate in green doesn't really change. It doesn't really increase. And these people can be very symptomatic. They can be very limited in their activity. These are people who likely are older patients and have some neurodegenerative disorder. If they don't have it at the onset, they will likely develop a neurodegenerative disorder. This is delayed orthostatic hypotension, where the blood pressure gradually drops. So these people are not, we would not really pick this up in a 10-minute stand. So this is a type of person that we would refer for a tilt if we're suspicious of that. And here we have the neurally mediated syncope, which we are all aware of. So this is just, to show some of the additional information, important information that we can get from a tilt. Not every POTS patient will need a tilt for diagnosis. So to go back to our case of CB, on further questioning, she did have a history of pre-syncope as a teenager. She did have migraines. So those two features, suggest that, yes, she likely will have an orthostatic intolerance syndrome, such as POTS. We did do orthostatic vitals, and we see that there is an increase, significant increase in the heart rate on standing of greater than 30 beats per minute. There's no significant drop in the blood pressure. The rest of the exam is normal. She does not have generalized joint hypermobility, which is assessed clinically using a Beighton score with a cutoff of at least 4 out of 9 to say that they have generalized hypermobility. ECG was normal, labs, echo Holter done by the referring physician was normal. So what do we do now? How do we manage this person? We have this decent algorithm from the CCS POTS statement. The first thing we do is non-pharm. So the very first thing is increase fluid and salt intake. And a lot of people have already done this by the time they come and see a specialist or see us in the clinic. This is something that really, we would hope that the primary care physician is instituting before even referring to anybody else. So fluid intake, salt intake, compression garments, and we're talking about full length compression. If tolerated. We actually give all our patients prescriptions for compression because they might have these covered under insurance or disability. Exercise is a tricky one. So it's, gradual recumbent exercise, but it does improve symptoms, improves quality of life, and in some patients may induce remission. If people are either don't respond to the non-pharm treatment or their symptoms are very severe at the time of presentation, then we will start medication as well. And what is written here in this statement and what we do in practice is we tailor the medication or aim to tailor the medication to the specific problem that the patient presents with. Sometimes we have to use medications in the different classes, and we use them synergistically at low doses, and that can be helpful. So for example, we might use propranolol in combination with midodrine, an alpha agonist for vasoconstriction, in addition to pyridostigmine, which is useful for patients who have low blood pressures. Pyridostigmine can be very useful for patients who have fatigue and even brain fog. We start the pyridostigmine at very low doses. In fact, so this is a medication that is used for myasthenia gravis. Often we have got pharmacists getting in touch with us saying, "Are you sure you want to prescribe such a low dose?" And we say, yes, we are. The limitation with the pyridostigmine is actually diarrhea, which is unfortunate because, as I said before, some of these patients can have a lot of issues with diarrhea. Fludrocortisone, if the issue is hypovolemia and low blood pressure. Again, Fludro is a good medication, and we see a good response to Fludro, particularly in people who have issues with oral fluid and salt intake. Limitation with Fludro actually is that it makes migraines worse. So those 40% of people who have migraines, we might not go for Fludro first off, or if we do, we started at a very low dose, so 0.05 milligrams actually, and up titrated gradually. Methyl-dopa and clonidine can be used for the hyperadrenergic type POTS, but we have seen limitations with these medications because patients have a lot of brain fog, and these make the brain fog significantly worse. If we are going to use methyl-dopa and clonidine, we would tend to use it at night. Infabridine here, Infabridine is like the wonder drug for some of these patients who have predominant tachycardia, particularly because it doesn't have that fatigue associated with it that the propranolol and beta blockers do. And also the Infabridine doesn't drop the blood pressure like the higher doses of the beta blockers may. The issue with Infabridine is the cost. It can be quite expensive, and it's not covered for this situation because it's seen as being used off-label. But it is something that works for patients who have predominantly tachycardia. I'm not going to talk about IV fluids, mainly because you see here it says third line. IV fluids, they can be useful as a rescue phenomenon, but as a long-term treatment option, use of IV fluids can be very problematic. It's associated with having to have IV access, and often people can then need to have long-term IV access with all the associated risks of infection, thrombosis, and the issue as well is that what is your ceiling for IV fluids? What is your target? It can be very difficult once you start IV fluids to actually wean people off IV fluids if you're using it long-term. It's different if you're using it as a bridge because they have some other concurrent illness or a trigger, specific trigger for a flare. I'll just mention this just to say that, you know, we actually don't have very many or if any long-term trials on treatment for POTS. But it seems in the last year, there have been a fair few studies published in JACC. Some of you might have seen them, some of them from our colleague, Dr. Satish Raj and his group in Calgary. So, you know, they're very small studies. We're looking at small numbers. This here is a study on the effects of high salt diet in POTS. So we're talking 14 patients and 13 controls. But it did show that a high sodium diet compared to a low sodium diet caused an increase in plasma volume, decrease standing norepi, and decreased heart rate. Another study again from Dr. Raj's group in Calgary, published last year, is a study on compression. So again, 30 patients with POTS completed this study, and they assessed the effects of compression during head-up tilt. And it was found that actually full compression was the best. And compression of the abdomen and the legs was more effective than legs alone. If you couldn't achieve this, then compression of the abdomen on its own might be considered. And, you know, in some patients, we asked them to use abdominal binders, people that cannot tolerate full compression, again, due to issues with temperature sensitivity. We asked them to wear shapewear so that the abdomen and the thighs are compressed. And this can be beneficial for symptoms. There's this study from Dr. Pam Tobe, also from last year, on Infabridine. This was, again, 22 patients with POTS, completed this study, and it was Infabridine versus placebo. Very nice study in JACC. So Infabridine did significantly lower the heart rate compared to placebo. It improved quality of life, and it decreased standing norepi. Again, we talked about the issue with cost of Infabridine, and you know, there's some maybe some limitation in the quality of life data in that the patients could feel that they were on Infabridine because they were aware of the heart rate lowering. But this was, you know, this was very impressive, and, you know, it hopefully will lead to more studies of Infabridine, and maybe even lead to Infabridine being covered by insurance. Okay, so our patient would be considered an intermediate severity. So we increase the salt and fluid intake. We prescribed compression, which she wore particularly when she was at work. We prescribed low-dose propranolol and sent her to cardiac rehabilitation. Her symptoms were improved. She was able to work, and she was able to modify her physical activity, so not running marathons, but able to run shorter distances. So our program at Women's, we get referrals from multiple sources, family physicians, cardiologists, neurologists, GIM specialists, headache specialists. So we have a lot of different subspecialties that we work with. We do have a multidisciplinary team. We have a specialist pharmacist that helps sometimes with quite complex pharmacology. Some of these patients are on multiple medications because of the other conditions they have. So we would be, frankly speaking, lost without our pharmacist. We have kinesiology, physio, nurse practitioner, and social workers. And we developed a boot camp program in cardiac rehab specifically for this group of patients. So the boot camp was started in November of 2019. Initially, we started an in-person boot camp, but then we had to pivot very quickly to a virtual boot camp. So we had 2 in-person, and then we've had 5 virtual boot camps so far. Small groups, a 6-week program, weekly sessions with exercise, education management, peer support, and we have had positive feedback from these patients on this format. Before this, we would refer them to the general cardiology rehab, and they found that that program wasn't sufficient or wasn't tailored to them. Often this was, as you can imagine, those were people who had ischemic heart disease, coronary artery disease, they'd had previous cardiac surgery. So it was really a different type of rehab, and the POTS patients would be enrolled, but they wouldn't attend. So that's how we developed this boot camp specifically for that group. So to recap, POTS is a clinical syndrome. There are hemodynamic and symptom criteria for diagnosis. An accurate diagnosis will lead to management that can improve the quality of life of these patients. The management consists of non-pharm and pharm approaches, and not every patient needs specialist evaluation, but definitely the more complex cases or cases that are difficult to treat will require a multidisciplinary approach. I'm just going to spend about a few minutes just to talk about POTS and COVID. We have, this condition called long COVID, which actually was driven and by patient advocacy groups. A lot of patients who had COVID early in 2020 and continued to have multiple symptoms, and they came up with this name long COVID themselves, and they did surveys, online surveys themselves of their symptoms, and there was anecdotal reports of increased referrals to autonomic centers, particularly in the States in late 2020. There were case reports of acute autonomic dysfunction post-COVID. And now there's more reports of autonomic dysfunction as a component of this post-acute COVID syndrome. What are the potential mechanisms of this? It's not clear, but these are some of the thoughts. So increased sympathetic outflow due to actual SARS-CoV-2 infecting the brainstem. So that's one potential mechanism. Is this a persistent autoimmune inflammatory response? We are aware of POTS, and we know that a viral infection is a trigger very oftenly for POTS. So is this in line with that? Is there hypovolemia due to RAS complications with SARS-CoV-2? Is there actual direct cerebral blood flow dysregulation? Is some of the brain fog and fatigue related to hypoxia from residual lung damage? And do some of these patients have an actual neuropathy post-COVID? Do they have a small fiber neuropathy, for example? You know, how do we treat people who have POTS after COVID? You know, do we just use the exact algorithm for regular POTS? I don't think we can, but some of the things we do advise and we can do. So, you know, hydration, salt. We don't advise exercise because there's a significant amount of post-exertional malaise in these post-COVID patients where exercise can actually make them worse. We do treat the predominant symptom and presentation. So we have used, we have used Infabridine in these post-COVID POTS patients where tachycardia is an issue. We have used pridostigmine because they have a lot of fatigue as a presentation and a lot of brain fog. Sometimes we use midodrine if their blood pressures are low, but we find that these group of patients are quite intolerant to midodrine. They have a lot of side effects with the midodrine. And just, you know, I know it's not in the treatment algorithm, but for these post-COVID POTS patients, they have a lot of mast cell features as well. So we refer them to our allergists and immunologists, and they're treated with antihistamines initially to see is there a benefit in their symptoms. They're treated with H1 and H2 antihistamines regularly. Some of them, you know, are put on mast cell stabilizers such as cromolyn, ketotifen, and some of them are even put on Singulair, and that can help the clinical picture as well. There's a lot of future questions in this particular group, you know, post-COVID POTS, you know, is this the same as regular POTS or is it different? You know, what is the exact underlying pathophysiology? What is the epidemiology? Some people throw around numbers of up to 30% of people post-COVID will have ongoing symptoms, and a percentage of them have palpitations and tachycardia as some of those symptoms. So, you know, that would be a huge number of patients that we would be talking about. Also, you know, the in regards to the natural history, we have had experience with patients getting COVID quite early on in 2020. They recover from their post-COVID POTS, and then unfortunately they get COVID again a second time, and they have a relapse in their symptoms, and you have to increase therapies again. So, you know, there's a lot of unknowns there, but these patients are referred to us and they're coming to us, and we try and manage them based on the symptoms and the pathophysiology that we see. So in summary, just again, you know, this is a chronic disorder. The main feature is orthostatic tachycardia. There are hemodynamic and symptom criteria that need to be met for the diagnosis. Sometimes it can be challenging to make the diagnosis, but if we can make an accurate diagnosis, then hopefully we can institute management that may improve symptoms and quality of life and functioning of these patients. We need more information as to long COVID POTS, how to manage it, what is the natural history, and what is the epidemiology of this particular subset of post-COVID patients. Thank you for your attention.
Great, thanks a lot, Tosin. That was fantastic. Maybe I'll just have you take down the slides, and I just wonder if anybody have any questions for the time being. If not, maybe I'll start one. There are house staff on the call, and I just wonder if you can give people, how would you suggest doing orthostatic blood pressure? Because often, they write down the orders like ED, please, do orthostatic, and it's always kind of normal, but when you do it yourself, it's often not. So I just wondering if you can give the house staff, some advice how best to do this orthostatic blood pressure.
Yeah, so in an ideal setting, you would have the person lying down, supine, start off with supine for at least 3 minutes and do a supine blood pressure and heart rate. Then you would stand them up and really try and measure blood pressure and heart rate in the first minute. And then, so for us in our clinic, we do it, every minute, but I know that's not going to be possible for a lot of people. So at least 1 minute, 3 minutes, 5 minutes. If you can do it up until 10 minutes, that would be good. If you get a sustained increase in heart rate over 1, 3, 5 minutes, more than 30 beats per minute associated with symptoms, then that would, I would take that.
So you don't really have them sit up, like lying, sitting, standing. You just lie, stand, just kind of do a tilt table like type of test.
So
David, yeah.
Hi.
David, I think it looks like you've got a comment.
Yeah, I have a question. First of all, I want to thank you so much. This is an extraordinarily complicated topic, and I just wanted to point out that philosophic asides are sometimes useful. I think this topic is right at the interface of the mind and the brain, and there's a lot of talk now about how the brain has lost its mind, and how, frankly, the need to integrate the two is probably the biggest part of where I see these patients in my therapeutic encounters. And the first thing they need to be told is they're not crazy and have an empathetic ear. And then the next thing they need to be told is we have to be careful in medicine to treat people from the neck up as well as the neck down. And on the neck up department, figuring out how to cope rather than searching for elusive nosologies whose therapeutic implication is not often there is the real issue. So I wanted to ask you a little bit about this problem exactly. For example, inappropriate sinus tachycardia is a different nosological classification that overlaps with POTS. Often the two are there, and you didn't really mention it. Of course, the NIH group tried to separate them for research purposes, but clinically, I think they're all kind of jumbled together. And the other big one, of course, is what's your take on the psychosomatic research access regarding this? Because clearly, this is at the nexus of the psychosomatic world and the somatic world. And our efforts to try to produce somatic pathophysiological explanations may be elegant, but need to be integrated back to the mind. Funny that you began with soldier syndrome and neurasthenia and the classic models of psychosomatic medicine. And I think that may be part of the full circle. And then therapy, I just want to endorse everything you've said. I can't tell you how often you meet these patients who are volume contracted by an iatrogenic volume contraction by a foolish view of what they think is a healthy lifestyle. And it's for everyone, you must really ask every patient that question. And the other one that's interesting, of course, is what is a remarkable occupational predisposition to this is quite common. Beyond the female disposition and its implications to psychosomatics, many of these patients are healthcare workers, usually not the most educated in my experience. They more have ancillary connections to the healthcare environment, often upright rushing around. Another particularly occupational predisposed group are teachers, again, another group will have an occupational drive to volume contraction. And then my only comment on therapy is to endorse every single thing you said. I think the mainstay is education, reassurance, empathy, and massive hydration. If they can change work in terms of that, that's nice, but not always possible. And the exercise regimen is key, I think, before any kind of medications. And supine exercise is the way to go. Swimming's a good one if you hydrate while swimming because of the ANF effects of submersion, but also one that's not mentioned enough. And then the medication one, I like the CCS therapy regimen. People should remember that Infabridine may be teratogenic. The data on that's unclear. And clearly the real mainstay is to have empathy, supportive psychotherapy, tell them that they need to figure out how to live in their bodies and cope with what their body does and how it works, rather than having any easy thresholds to medications. Last one on IV, I had one terrible crisis patient who was on everything that you can imagine. And she foolishly was told to have a PICC line with saline infusions, and it was a catastrophe. And in that very rare case, I was able, again, just with the psychotherapy approach I've just mentioned, and her family doctor proposed chlysis, which is a very old-fashioned way of giving fluids that was far safer and far more effective. It's not done. But I have a feeling she was so psychomatically charged by generating this grapefruit-sized bubble in her abdominal wall of saline that slowly resorbed, that allowed her, I think, to figure out ways of coping that it gave her such a good preoccupation somatically. At any rate, thank you again. I think it's a great and very complicated topic. Last thing on tilts, I think we're the only tilt lab left. And the value of tilts in this condition, I think, I agree with you completely, is very modest. I think the biggest role of tilt is education and reassurance. And that you don't need a tilt for. And if they're not fainting, I'm not sure the tilt has a role, but unless you're doing research, of course. Anyway, such a few of my comments.
One of the realistic comment from Cam is that you're very popular today, Tosin. Like he is asking, like, you know, if we need your help, how do we refer to you?
So you refer to Dr. Paula Harvey at Women's College Hospital.
Sounds good. Perfect. And there, and then Eugene probably could help out as well. But thanks, really thanks, Tosin, for coming. You know, this is, as David said, is so complicated, and I think that, you know, we often ignore the needs of patients because we really don't know what to do. So I think it's really give us some insight about, you know, this is a real condition and we have to think a bit more about it. Just to close out for those who are here, you know, next week we're going to have a special round from Umbrin. She's an internist. She's going to talk a lot about allyship, diversity, equity, and inclusion, and she's, you know, had played a really strong role at the university as well as at Sunnybrook for that. So I welcome everybody for coming tomorrow, and we're going to have some didactic and some discussion around it. So thanks a lot for everybody. Thanks, Tosin, again for coming. We'll see you soon.